Hello everyone. Today we will be going to discuss about the next chapter of gastroenterology, that is irritable bowel syndrome. The first question that will arise in your mind is what is irritable bowel syndrome? So the thing is, there is the functional loss inside your intestine that is called as the irritable bowel syndrome. The structures are almost same, but the function is lost. We can learn it with one example that there are two persons who ate the same type of meal, but one is normal and one got pain, diarrhea, distension, and bloating. So we can say that the person is suffering with the irritable bowel syndrome. But why this irritable bowel syndrome gets caused? This gets caused because of stress, because of anxiety, or because of overeating. There is increasing in hypersensitivity inside the intestine. The another reason for this is neural coordination. We all know that our brain and our intestine are coordinated with the cingulate cortex. So there is hypersensitivity of the cingulate cortex, which will lead to irritation and causing this irritable bowel syndrome. So what are other associations along with this irritable bowel syndrome are lactose intolerance, celiac disease, fibromegaly, and chronic fatigue syndrome and general anxiety. This can also considered as the associations which are present along with this irritable bowel syndrome. So, clinically, where does this irritable bowel syndrome occurs? It occurs majoritarily in female as compared to male, and the age group is less than 45 years. I will talk about the abdominal pain. Roman 4 criteria. There will be recurrent abdominal pain. There will be minimum one episode of pain per week for more than or equal to 3 months. Then we can consider that he might be suffering with this irritable bowel syndrome. And there should be another criteria that it should have frequent stools as well as the stool form. The appearance of the stool should change. These are the main points. And according to the site, it should occur in lower abdomen. Like you should get cramps in lower abdomen, and you should get frequent episode. Like you should get one episode of this diarrhea per week or constipation, depending. Aggregative factors, stress and eating. This creates aggression inside this disease. And relieving factor, defecation. Whenever you will defecate, you will get the feeling that okay, I'm all right, but this syndrome will occur again the next week. The alternate bowel habits. There will be irritable bowel syndrome of three types basically. First is the irritable bowel syndrome diarrhea. Second is the irritable bowel syndrome constipation, and third is the irritable bowel syndrome mixed. So this is denoted as D plus, C plus, and M plus. This M plus means diarrhea is predominant. There will be small volume associated with mucus. In C plus, there will be constipation predominant. In mixed, there will be both episodes of diarrhea as well as constipation. You will see alternately. Then there will be abdominal distension with bleaching. Bleaching is nothing but a fancy name for burping. Then you will experience dyspnea, that there will be pain in the heart. It is not basically in the heart, it will be in the esophagus, but at the location of heart. And you will also experience nausea and vomiting. Then there are features against the diagnosis of irritable bowel syndrome. If you suffer nocturnal diarrhea, steatorrhea, blood in stool, fever, weight loss, anemia, malabsorption, or increasing in ESR, these are just the false feature where you will experience this irritable bowel syndrome. What is the pathology of this irritable bowel syndrome? So pathology is basically unknown, but we have a theory to prove this symptom. We will take the symptoms and we'll make the theory out of it that it might be occurring like this. So this same theory was made, and it is called as the theory of visceral hypersensitivity. There will be, if there will be minimum rectal distension, like there will be very little stretching, still it will cause a lot of pain. This was the first postulate of the theory. Then the second postulate is increasing in colon motor potentials. Then the third is the activation of cingulate cortex. If the cingulate cortex is activated, there will be hypersensitivity. Then there will be increasing in the serotonin containing chromatin cells. You know that the chromatin cells are responsible for secreting serotonin. So the intestine will have large production of these chromatin cells, and the serotonin will be gradually increased. Phenyloid channels, these are TRPV1 channels. This acts as pain receptor. or pain receptor. Pain receptor. Apart from this, so diet and lifestyle. This will improve the 70% of the cases, but in 30% of the cases, medical management is required. 70% of the cases are improved with the changing in lifestyle, continuous lifestyle, and the 30% will require medical management. So, what are the changes? What are required inside this management? Here, you should be walking 6,000 to 8,000 steps per day. You should reduce the FOD MAP intake. What is FOD MAP intake? We will call it as food map intake. Food map intake refers to fermentable oligosaccharide, disaccharide, monosaccharide, and polysaccharide. If you avoid eating this, there will be no fermentation. If there is no fermentation, there will be no formation of gas. And if the gas formation is reduced, the pain present inside the intestine will gradually decrease. So that is the concept behind this. Sources of this fermentable oligosaccharide, disaccharides are apple, mango, wheat, honey, legumes, cauliflowers, etc. Wherever you will see sugar, almost you can cover it that wherever you see sugars, because monosaccharide, disaccharide, polysaccharide are present basically sugars. So this compound containing a large amount of sugar, you should avoid them. That's the thing. So the point of medical management. In medical management, first you should be careful that the person is suffering with IBSD or IBSC. What is IBSD? That is irritable bowel syndrome diarrhea and irritable bowel syndrome constipation. So irritable bowel syndrome with diarrhea is there, so you should be giving diarrhea related drugs. That are four types of drugs. You should be giving lopramide. You should be giving antispasmodic drugs, antidepressant drugs, and some of the oxalate drugs that are used. For example, the oxalate drugs are allosterol, which inhibits the which acts as antagonist for serotonin, which inhibits 5-hydroxytryptamine, and the side effect is ischemic colitis. Then you should be giving ulixlodone, which is potassium antagonist, which is K antagonist, which is gamma antagonist, and it causes pancreatitis, and some of the drugs that are cardiac toxin. In constipation, there will be stools that are bulking. So there will be bulking agents, two bulking agents present. We are basically trying to inhibit them. So for that, we should be using drugs, lubiprostone, linsinotide, and tenofovir. So here, lubiprostone, what it will do, it will act on biocycling fatty acids and it will activate this calcium releasing channels. After that, the second drug is linsinotide, that is guanylate cyclase antagonistic, and the third drug there it will be sodium hydrogen exchange blocker. And the note point which is written here that these drugs will be more effective in the presence of antibiotics, probiotics, and prebiotics. And that's it for today.